I'm Ms. Ulcer. I'm an outreach specialist for the Lindner Center of Hope. We're thankful to the Countryside YMCA for giving us this space for the community education presentations. Tonight we're excited with Dr. Lindsey Conover, as you can see. And the reason you came tonight was maybe before for the topic as well. But before I turn you over to Dr. Conover, I want to share a little bit about the Lindner Center of Hope. Before I do that, I want to say thank you to community partners, Bob and Mary Ehlers, and Dr. Jim Chin, who I know is on the virtual. We have people all over the world right now virtually. So hello and thank you for joining us. Thank you for taking the time. And somewhere it is the wee hours of the morning that they're jumping on this. So we appreciate you. A little bit about the Lindner Center of Hope in Mason, Ohio by Kings Island. We are a nonprofit. We have 80 beds. What that looks like, lots of treatment going on at the Lindner Center, a lot going on. We do inpatient, we do partial hospitalization, intensive outpatient for addiction and co-occurring. We have a full outpatient practice, psychiatrists, psychologists, nurse practitioners, therapists. We have a full continuum for eating disorders from crisis inpatient, partial hospitalization, intensive outpatient, and a full Harold C. Schott eating disorders team. We do neuromodulation out there, which is for treatment-resistant depression. One is called electric convulsive therapy, ECT. The other is TMS, transcranial magnetic stimulation. As well, we have a residential side where we are doing we're stabilizing individuals, where we can do detox, medication management, and evaluate what could be driving the addiction. And on our other residential unit, we are able to do a comprehensive diagnostic assessment where we're surrounding an individual with a team. Could be individuals that come in 18 and over with diagnosis or without diagnosis. We want to surround them with a psychiatrist, psychologist, social worker, and really tease out what is going on and provide a recommendation for them and refer them on to a next step for treatment. Also, we have something called Rapid Access, which is 2 afternoons every week where people can come in. It would be for the individuals, let's say you're trying to get into a psychiatrist or maybe a nurse practitioner. They're booked for maybe a month or longer, and that's just too long to have to wait. So it's called Rapid Access. And you can call in, get an appointment on a Tuesday or a Thursday, see a psychiatrist, a social worker, and get a recommendation for treatment. You can come back for 3 appointments, and hopefully you'll be in to see a psychiatrist or a nurse practitioner, potentially at the Lindner Center or somewhere else. We get full as well, and we certainly can try to help with finding a psychiatrist out in the community or a nurse practitioner. Dr. Conover also does work on our OCD track on our residential side of the Lindner Center. We take a lot of commercial insurance, and our residential is private pay. So that's a quick overview. I won't ask you to repeat anything back to me, but if I can help, that's what I do. I go out and grow the awareness for all the treatment we do at the Lindner Center. And we're so thankful to be able to offer this community education. Don't make sure you all have next year's agenda. So without further ado, I'll introduce Dr. Lindsey Conover, clinical psychologist, part of the OCD and anxiety team at the Lindner Center of Hope. And as I mentioned, she does work on the residential unit and also runs the OCD track for the residential side. So I give you Dr. Lindsey Conover.
Thank you. All right, so hopefully I can provide some information today about how, about anxiety and OCD and how you might be able to help loved one, whether that's a child, sibling, a family member, a friend. I'll try to be broad, but it can look different depending on your relationship with the person, right? The first thing I think is really important, and I'm gonna spend a lot of time on this, is in order to know how to help somebody, you have to know, educate yourself about anxiety, about the available treatments out there, and, you know, what it looks like, so you can maybe identify warning signs, so you can identify helpful things, unhelpful things. So we're gonna, hopefully, you all will learn about specifically cognitive behavioral approaches to treating OCD and anxiety disorders, learning to identify warning signs and where to look for help, and learning some evidence-based strategies you can use to support your loved one. So starting really basic, what is anxiety? You could use so many definitions to describe this, but I'm going to use sort of biological framework. So when we are faced with a threat, our body, our brain often respond either with a fighting response, like I need to face this threat. So imagine you're faced with a bear. I personally am not going to get ready to fight the bear. I'm going to be fleeing, so that's the flight. But depending on the threat, your body might be getting ready to fight the threat, flee the threat, freeze, or fawn. So in a physiological sense, this might mean you're slowing down your digestion. You don't need to be digesting food when you're dealing with a threat, right? That's like a secondary issue. So that could be why some people with anxiety experience digestive distress. You might experience increased heart rate, increased breathing. You gotta do that when you're facing a threat, right? You gotta be alert, you gotta be ready for action, you gotta be ready to run really fast or fight the thing. You also might have higher stress hormones like adrenaline, cortisol. This is in the sympathetic nervous system. So looking at this from a physiological point of view, all of these things are good, helpful things that our body and our brain do to try and help us face threats effectively. Freezing, think of it like a possum laying dead on the side of the road, right? Sometimes freezing, making ourselves as small as possible might be the thing that our brain thinks will keep us safe. And then fawning, like seeming like a non-threat to the threat, or making things okay for another person. Might be what we think is going to keep us safe. There's also a cognitive component. So cognitive means thoughts. So when we're facing a threatening situation, we are going to, it's going to be more effective and efficient for us to take our thoughts and take action on our thoughts and think our thoughts are fact and real and important, and so we just gotta go with it. This can sometimes be unhelpful when we are not in a directly threatening situation and our thoughts are making us feel more anxious than we need to be about a situation. So I may have a thought like, I'm gonna totally bomb this presentation and then I'm gonna get fired, and then I'm never gonna get a job again, and then I'm gonna be homeless. And if I believed that to be true, because it's a thought I have, then that would probably be unhelpful for me and I would probably crumble up here on stage. But evolutionarily speaking, when we think about our thoughts and we're facing a threat, it might be more helpful to think of it as facts. So another thing we might try to do is problem solve. This is really helpful when the problem can be solved. Not so helpful when we don't have control over the problem. So if we don't have control over it, we might just worry and worry and worry and try to plan ahead and try to predict the future, and it feels like problem solving, but it's not really problem solving. So we can get into a situation that's not helpful in that sense as well. And then finally, behavioral. So there's a behavioral component to anxiety. We're fighting, we're fleeing, we're freezing. So we might try to fix the problem or avoid the problem, because then our anxiety goes down, we're away from the threat. So that can be helpful in a situation, but it may also be unhelpful when we're avoiding things that are not actually threatening to us, or when we're trying to fix things that are not fixable, or that will just make us more frustrated to try and fix things that we don't have control over. And over a longer period of time, the physiological responses can create long-term cortisol in our bodies, long-term stress on our bodies, and avoidance over a period of time, if you avoid more and more and more, can make your life smaller and it really impact your quality of life. So these can have impacts over a longer term. Okay, so we know what anxiety is. Anxiety is normal, especially during stressful situations. So when I'm working with patients, I'm never like, anxiety is bad, we don't want to have any of it. Like, we definitely need to have anxiety in certain situations, and it's normal. You're going to experience anxiety. You're a human person. So things like starting school, dating, if you experience death of a loved one, unexpected traumatic events, learning to drive, marriage, parenthood, aging, all of these things, we're faced with the unknown, the unexpected, and it's normal to experience an amount of anxiety. It can also be helpful. So if we didn't have anxiety, we might be okay with standing in the middle of traffic, right? Like, anxiety kind of gives us information about what is safe and what is not safe. We can use it at times as a helpful cue to know how to behave in our environment. Moderate test anxiety can help us to perform at our best. It can help us to have access to all of our cognitive abilities and help us be alert. Same thing with presentations, performance. A bit of anxiety help us to perform a little bit better. What we're looking for an anxiety disorder is significant interference or distress. So that means, is the anxiety getting in the way of an individual's life? Is it getting in the way of school? Is it getting in the way of work, so that you can't do what you need to be doing? Is it getting in the way of social relationships? Is it getting in the way of your mood? We'll talk about that a little bit more later. And then also significant distress. So is the distress you experience manageable? Is it something where you can, if you try really hard, turn your attention away from it? Or is it not that manageable, where it's really persistent and it's all you can think about, and it's not something that you feel like you can tolerate? Is it incapacitating? Those types of things might make someone, rise to the level of it being a clinical anxiety disorder. So these are some anxiety disorders. I just want to note that I threw PTSD in here, post-traumatic stress disorder. It's not an official anxiety disorder, but people who have PTSD have a lot of anxiety, so I put it in here. This first acronym, GAD, stands for generalized anxiety disorder. That is people who worry a lot about a lot of things. So it could be worrying about your future, worrying about your finances, worrying about your performance, worrying about friendships, worrying about your health, the health of other people. This can often lead to physical symptoms like restlessness or feeling really tired all the time because you're worried. You're doing a lot of mental work all of the time. It can also lead to like tension in your body. Panic disorder is you have panic attacks and you also worry about having future panic attacks. So it's not that you just have a panic attack every now and then, but you're also consumed with worry about when the next one will come, and you might change your life in order to try to prevent them in a way that's interfering in your life. Separation anxiety disorder, more common in kids, but it can be diagnosed in adults. And the idea here is that you have anxiety being separated from a safety person. So that might be fear of just being in a different room than that person, or being like having a sleepover at someone else's house, or going to school, or being apart from that person in a way that's excessive and not developmentally normal. Illness anxiety disorder is pretty much what it sounds like. Anxiety about having an illness, and oftentimes people who have illness anxiety disorder. So this used to be kind of like hypochondriasis. So like, I think I have an illness and I'm really worried about it, and I may do a lot of things to try and check my symptoms or make sure that I'm okay. Post-traumatic stress disorder, again, it's not officially an anxiety disorder, but it's having experienced a traumatic event and then having persistent stress even after that event is done and you are in a safe environment now, but you're still preoccupied, still really fearful, still hypervigilant, still having lots of recurrent and distressing memories of the event. And then phobias, you know, specific fears. And a lot of people have specific fears, but this is really when it's something that's getting in the way of your life, and your avoidance of that thing interferes with other things you want to be doing in your life. So for example, I am afraid of roller coasters, but I'm cool not going on roller coasters, and it doesn't really impact my life that much. If I was afraid of microphones, we might be talking something different. Okay, and then OCD used to be categorized under anxiety disorders, but it's now its own disorder. Obsessive compulsive disorder can be, the content really doesn't matter. It can be about a lot of different things. The components that are part of OCD though are obsessions, which are recurrent, unwanted, uninvited, intrusive thoughts. They can also be images, they can be feelings, they can be urges that increase anxiety. So it's not something you like. You know, people say like, I'm obsessed with Taylor Swift or whatever. It is something that is creating a lot of distress. So the difference between an obsession and something you worry about is like an obsession is usually focused on one pretty specific topic or an area of fear rather than worrying about lots of different types of things. And usually they come in like a lightning bolt, and you're afraid and you feel like you have to do something to make it better or to prevent negative consequences. And that's when compulsions come in. So compulsions are repetitive behaviors or mental actions that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. So compulsions are things that bring down anxiety, or at least things you think are going to bring down anxiety. So in the context of OCD, you get anxiety, you get a thought, it causes anxiety, you do something to try to make that anxiety go away, and you're in this cycle of like anxiety coming up, anxiety going down, anxiety coming up again, and then I have to do more of the thing that makes the anxiety go down, that sort of thing. It has to be excessive or not connected in a realistic way to what it's designed to neutralize. So some people with OCD will have a fear that, like a superstitious fear, like if I don't hold my microphone with this hand, then it's gonna be a bad presentation. So that would be not connected in a realistic way to what I'm afraid of. Or it might be clearly excessive. So washing your hands is a realistic response to contamination, but if you do it for hours and hours a day, that's clearly excessive. Things that almost meet this criteria but don't might be like double checking the car door when your car only locks 50% of the time. Like, it makes sense to check it again because it doesn't always lock. Washing your hands because work requires that you wash your hands a certain amount of time. Or praying according to your religious norms or when in hard times. It might be excessive if you developed your own rules for praying that are outside of what everyone else in your church does and that are excessive and getting in the way of your life. Okay. Some common types of compulsions are washing, checking, reassurance seeking. So asking other people and trying to get reassurance that everything's okay, right? So like, this microphone's okay, right? Does everyone agree that it's okay? It's not gonna make me have a bad presentation. We all think so. It could also be researching on Google again and again and again, not like in the first article we go to, and a lot of us can have these tendencies, right? Anxiety is normal. Responding to anxiety in a compulsive way can also be normal. Again, we want significant interference or distress for it to count as OCD. So research has found that a combination of psychotherapy and medication is helpful for those with moderate to severe anxiety disorders. But in mild to moderate cases, a lot of people benefit just from psychotherapy. And I put down here some of the evidence-based types of psychotherapy. So cognitive behavioral therapy, if you've heard of CBT, that's this. Mindfulness and acceptance-based therapy. I also put on here eye movement desensitization and reprocessing. That's more specifically for PTSD. If you've heard of EMDR, that's more for PTSD. But I'm going to be talking mostly about cognitive behavioral therapy because that's the therapy that I know the best. And it's also the oldest of the evidence-based approaches that are used today. So this is the CBT model. So in cognitive behavior therapy, we look at anxiety through different components. So the thoughts you have, the feelings you have, and the behaviors that you do, and how these things kind of interact to maintain the anxiety, keep it going, that sort of thing. So as an example, if I see a large spider, I might think that spider will probably bite me. And I might feel anxious, and then I might run away from the spider. If I thought, oh, what a cute little spider, that might make me not so anxious. I might feel calm. So in this way, we can see how the thought influences how we feel. I also want to note that in this graphic, the arrows are going one direction, but they can really go both directions. And thoughts, feelings, and behaviors can all kind of interact. If I were to run away, that reinforces the thought that that spider would have probably bitten me if I hadn't run away, right? I don't get evidence to the contrary. And next time I see a spider, I'm gonna think the same thing and I'm gonna run away because it felt good last time to run away, so I'm gonna run away again. So the behavior is reinforced by the anxiety coming down, and the thoughts and the beliefs are reinforced as well. And if nobody challenges my thought, I will continue to think that that is true. Another example would be touching a dirty toilet seat. I may have the thought I'm contaminated, I might feel anxious, I may then wash my hands. Again, washing hands reinforces the thought that I was contaminated in the first place, that whatever I had on my hands was really dangerous, that I couldn't tolerate the anxiety, that anxiety is bad, all of these things. And the thought of I'm contaminated brings on anxiety versus if I thought like, cool, dirty toilet seat, which I'm not sure anyone, but our thoughts definitely impact how we feel. Okay, so in CBT, we really try to break apart this cycle, and we do that by targeting different elements. So with thoughts, we might do cognitive restructuring. So what that means is just looking at your thoughts, maybe questioning them, taking a second look at them, right? If the idea is that they're factual, then we're just gonna believe them to be true and act accordingly. But thoughts aren't always factual. I imagine that you have had thoughts that weren't factual. And it's helpful sometimes to question them. Am I biased right now because I'm nervous? Am I predicting the future when I don't have that ability? Am I assuming what people are thinking of me when I can't read minds? That sort of thing. So we're trying to target the thought piece to eventually impact downstream the feelings piece. We can't really impact feelings directly. That's like saying, stop feeling anxious. Stop, don't feel anxious right now. But we can impact the physiology a bit. So if your heart is racing, and you're feeling anxious, we might do something to try to bring the heart rate down or slow your breathing, that sort of thing, which then can impact the anxiety feeling. And then for behavior, we do exposure therapy often for anxiety disorders. What that looks like is doing things that make you anxious, and if you do them enough, you'll get used to them, you'll realize that the fears you have weren't warranted, or that you can tolerate more than you thought you could tolerate. And the response prevention piece is if you're doing things to bring your anxiety down, if you're doing compulsions, if you're doing other things to reinforce the anxiety, we would have you try and voluntarily not do those things when you do the exposure. I want to briefly talk about medication options, but disclaimer, I'm not a medical provider, so please don't ask me any questions. There are two kind of common types of medications that are used in anxiety disorders. The first is serotonin reuptake inhibitors, so SRIs. So common types of these would be Zoloft, Lexapro, Prozac, Effexor. These can take several weeks to build up in your system. So if you take one and you're like, I don't feel better yet, you're not supposed to yet. It takes a while to build up, and you have to take them every day and consistently to maintain their effectiveness. And then another category is benzodiazepines. So that's like Xanax or Ativan. These are shorter term and have an immediate effect. So you take it, you feel better immediately, which can feel really good in the moment, but it can be habit forming. So you might start to feel like you need to depend on these in order to live in your life. And you might need more and more and more as you take them. So things to be aware of, and depending on the medical provider who you see, they may think that you should take both of these, one of these. It really depends on your individual case. And these work well, especially in combination with psychotherapy, and this is particularly true for more severe cases. I want to talk about levels of care because outpatient therapy isn't the only option, and some people really need more than that depending on how severe their anxiety is. I also want to note that if after you get all this information, you don't know what level of care your loved one would need, I would encourage them to go to a mental health provider and they can help recommend a level of care. So the outpatient level of care is usually 1 or 2 times a week. You're living at home, you're going to somebody's office, or you're doing teletherapy in your home. This is helpful if someone can still work, still go to school, still be really functional. They may have 2 different therapists working on 2 different things, or they may be in an outpatient group and also see an individual therapist. Individuals who really benefit from this level of care have the ability to take what is said and what is recommended and apply it independently in their life. They can monitor their symptoms over the week, come back in, discuss what they notice, maybe do an in-session exposure with their therapist, and then do homework on it independently, that sort of thing. Intensive outpatient is another level of care. Oftentimes, what's really helpful for people with OCD specifically is going to a specific IOP that has that specialty. But if you have generalized anxiety or other types of anxiety, you might benefit from a general intensive outpatient program. The skills learned in there might be helpful. So this is oftentimes a program where you meet 3 to 5 times a week for 1 to 3 hours at a time. There's group, individual, it really ranges depending on the program. And so this is if the anxiety problem is more severe. You might be struggling to perform adequately at school or work. You might be needing to take time off, reduce your workload. You may need more accountability and frequency in implementing the therapy tasks. You might need more frequent directed exposures, more opportunities to practice skills in a structured setting, that sort of thing. Then the next level is partial hospitalization. So this is for more severe cases. Again, you're living at home, but you are going somewhere like for the whole day, for the whole week. This is for people who really can't work, can't go to school. They may have to take a leave of absence. They need a lot more support because their symptoms are significantly interfering in their daily life and they're not able to implement skills independently. They need daily reminders several times a day to use their skills, daily challenging of their thoughts maybe, or practicing mindfulness, practicing exposures, that sort of thing. And then residential is a level up from this. So this is often voluntary and it's an intensive, and by inpatient, I mean you're living there, you are doing therapy there, and you're staying there. And they often stay for a month or longer. So this means you can't go to work or school. A lot of residential programs are out of pocket, but some will take insurance. So that may be a factor in determining if you can do a residential level. It's for people who need a structured living environment, really close medication management, receiving added support in their living environment, like people checking to make sure you got up, people checking to make sure that you are out and active and doing helpful things throughout the day. There's also expectations for getting up and out of your room and those types of things. And then inpatient hospitalization. This is more for if you're in a crisis and there's a risk of harm to self or to other people. They need stabilization. This can be voluntary or involuntary, meaning if you go to a mental health provider and you share with them that you have a plan and you want to try to die, then your therapist may say, we're going to the hospital, we gotta go to the hospital now. This is short-term and meant for stabilization. Often daily group therapy is offered, but really they're trying to keep you safe until you're through that crisis. There's a higher psychiatry presence and they focus on medication stability and just support in just functioning. Okay, so how do I know if a loved one is suffering from an anxiety disorder specifically? I kind of went over these already, but anxiety might be a problem if it's, oh goodness, can you see this? Oh no, that was me on my side. Okay, it might be a problem if anxiety is getting in the way of work or school, if it's getting in the way of friendships or personal goals, if it's negatively impacting their mood. So like, I'm anxious all the time and now I don't really feel joy a lot of the time, or I'm not as interested in things that I used to be interested in. The anxiety is taking over all of my time. And it could also be a problem if it's causing significant strain on the family. So sometimes for the individual, it's not that bad, but the family is doing all of these things, jumping through hoops to make the person's life okay, and the family is so stressed out. So that can also be a sign that there's a problem and that the individual might benefit from some help. Can you guys see this okay? All right, so oftentimes, like I said before, people with anxiety might seek reassurance. We will show this table to a lot of our patients, and I think it's helpful to figure out if they're asking for information or asking for reassurance. And why this is important to distinguish is because if I'm asking for reassurance, it's meant to try to calm my anxiety, and it might be reinforcing my anxiety. If I'm asking for informational purposes, then maybe it's helpful, maybe it's going to be a healthy action for me. So an information seeker asks a question once and is satisfied with the answer. A reassurance seeker repeatedly asks the same question, right? So I'm gonna ask you over here if this microphone is okay for me to use or if it's gonna hurt me. And then you say, yeah, it's fine. And I say, okay, what about you over here? Do you think it's okay? What about you? Do you think it's okay? Or I may ask the same question again and again. I'll ask you tomorrow if the microphone's okay. I'll ask you the next day if the microphone's okay. If you say it's okay, I might say, are you sure? But I don't know. That may be a sign that I'm seeking reassurance. Asking questions to be informed versus to feel less anxious, accepting the answer provided versus responding by challenging the answer, asking people who are qualified to answer. So I don't know if anyone has ever like shown someone a bump on their arm, like, do you think this is skin cancer? Like, I don't know, I'm not a doctor, right? So if we're information seeking, we're asking people who are qualified, we're looking at sources that are reputable, that sort of thing. That may be a sign that I'm seeking reassurance and trying to calm my anxiety in the moment. Seeking the truth versus seeking a desired answer. When I lived in Arizona, I was nervous about scorpions. And I was afraid that they were in my house. And so I researched scorpions in houses in Arizona likelihood. And I wasn't really looking for the likelihood. I was wanting an article to say, Lindsey, you will not have a scorpion in your house for sure, definitely. And that doesn't exist out there. So that was a sign that I was seeking reassurance when I'm researching, and I wasn't seeking information in that case. Accepting relative, qualified, uncertain answers when appropriate. So if the person's like, I don't know, you're like, okay, yeah, you don't know. Versus someone who's anxious and seeking reassurance might insist on an absolute, definitive, yes, for sure you are safe, I am certain of it. Someone who is seeking information pursues only the information necessary to form a conclusion. A reassurance seeker might indefinitely pursue information without ever forming a conclusion. So just on and on and on and on asking to try to calm their anxiety. Okay. So some things that can be helpful. First thing is educating yourself. That's what we're doing right now. That's what we spend a lot of time on. Another thing that I didn't have in here is validate. So like express like, this is really hard. I see this is really hard, and trying to support them and share that you're there for them, empathize with them, that sort of thing. If you feel like their anxiety is causing a problem, then encourage them to seek mental health treatment. If you have a physical problem, you go see a doctor. If you have a mental health problem, oftentimes you need a professional that can be helpful. I can't be, and I'm a therapist, I can't be my husband's therapist, I can't be my sister's therapist. If you're trying to be a loved one and a therapist, that's too much on you, and you may not be as qualified as someone else to help with that. You can support in asking about their treatment if they do get engaged in it, helping them to find treatment, encouraging regular attendance. How did it go? Did you go last week? How was it? That sort of thing. Also be aware of your own anxiety. Oftentimes when our loved ones are anxious, that makes us anxious. We don't want them to be distressed. We don't want them to be upset. We don't want them to be having problems or sad, and we might act out of that anxiety in a way that's not helpful for them, but calms our anxiety. So be aware of your anxiety and how that's influencing your decisions about supporting. And we'll talk a little bit more about things people might do when they're anxious. Seek your own therapy if you need to. If your loved one is struggling and you have an intimate relationship with them and it's impacting your life significantly, you might need your own support. Maybe that's not therapy, maybe it's a support group. There are support groups out there for loved ones of people with anxiety disorders, but seek your own support if you need it. There's also sometimes therapists who will work with parents on how to parent their anxious child and giving you suggestions and giving you advice. There's also family therapy options, couples therapy options. If it's influencing the family, you can definitely pursue that. I wanted to talk about some unhelpful ways. I also want to have another disclaimer that all of these strategies are helpful in most scenarios, but if you're in a crisis, it may not be as relevant. If your loved one is in a crisis, it may not be as relevant. So these are more like helpful and unhelpful ways to respond in general over a long period of time. First thing is rescuing them. So if you're anxious, you may want to rescue the person so that they don't feel anxious anymore. That might mean doing things for them. That might mean taking your whole day or days to spend time with them and to make sure they're okay and to make sure they're calm and to take away their anxiety. Why this is not helpful is because it reinforces the individual's thought that my anxiety is dangerous, anxiety is bad, and I need you to take it away. I can't do it myself. And long term, it's not sustainable either. They're not going to always have someone there to rescue them, and we want people to be able to cope more independently. On the other side of the coin, being tough love, dismissing anxiety, or ignoring the person is also not helpful, right? Like, you shouldn't be anxious about that. Just go, just do it, it's fine. That person may feel more hurt. That may reinforce their fear, might make them more defensive, less likely to come to you in the future when you might need to help them. Yeah. Another thing that I think people can get in the habit of is trying to apply logic to someone else's anxiety. Like, that's not really realistic, and that won't happen, and you're gonna be fine. A lot of people with anxiety know that their fears are illogical. They don't need you to tell them that they're illogical, and they may experience some shame and invalidation from that as well. Encouraging avoidance is often not helpful. So that would be like, oh, you're afraid of the spider, you should go leave the room now. Or why don't we just not do that then? That is unhelpful because it's putting extra ideas in their mind about how they could escape their anxiety, which we talked about kind of reinforces the anxiety cycle and reinforces the idea that anxiety is dangerous. Spending large amounts of time trying to apply logic or to reassure them. Again, this pattern can be reinforcing to the anxiety and also create a pattern of increased attention. So I get more attention from you when I'm anxious, And so I'm gonna do more of that because I like feeling important and feeling like my problems matter, and I'm sure all of us can appreciate when we're getting more attention. So that can also be something that reinforces anxiety. All right, and then finally focusing too much on their worry-related content. If they're worried about something that they have no control over and you're trying to help them problem solve, you might just be involving yourself in their worry spiral. And that's not super helpful because that just kind of keeps them in their anxiety and reinforces the belief that this thought I have is important, it needs to be solved, and that I need to pay a lot of attention to this. Oftentimes, our loved ones won't seek help, even though we want them to. And that can be really frustrating. So I want to talk about some reasons that someone may not seek help. Firstly, I want to kind of normalize the idea that putting off addressing a problem is so common. Like, I really should be working out more. I'm not doing that, right? We all have things that we think that we could work on or that we think are really important to do, and we're putting them off. And so our loved ones may be doing the same thing with this. Sometimes it's because they don't have insight that their anxiety is a problem in their life. Maybe they don't see that it's a problem, and that can be for a variety of reasons. Maybe they don't see how it's impacting their life. They're like, yeah, it's fine that I shower 7 hours a day, that's cool with me. That may, and you as a loved one can have the perspective that maybe that won't be helpful for them in the future when they want to have a job and they can't fit that in. So insight can get in the way of seeking help. Also, motivation for change. If the individual doesn't have motivation to change, then they're not going to be seeking help to try and change those behaviors. And then fear. Not only is there stigma to seeking help, but there can also be a lot of fear around anxiety treatment, especially if they know that maybe they're gonna have to do exposure to the thing, then they may not want to because that's scary. And so that is a really common reason people don't engage in treatment, fear. Something that I think is really important to resist doing is nagging the individual, not just nagging like, when are you gonna do this? Come on, do it, in regards to seeking treatment, but also nagging them to change their behavior. It gives the implicit message that you can and you should change right now, and doesn't acknowledge how hard it is for the person to do that. And it gives them pressure, which may only produce more fear and defensiveness. Another thing to think about is managing your own shame and guilt. A lot of family members of those who have anxiety may feel like, what did I do to cause this? Or I'm responsible for making sure that this person is okay. Both of those things are generally not true. There is a large biological component to anxiety, and usually there's many factors at play, and it's also not your sole responsibility to make sure someone else gets help. And then finally, reducing accommodations to help increase their motivation. Accommodation is a huge topic that I talk about with my families, the people that I work with. And what that means is creating, like interacting in your life to accommodate the person's anxiety. So we're going to talk a little bit about accommodation and what that looks like. So family accommodation might look like participating in the avoidance or in the compulsions. So sometimes when someone has a compulsion, but it's really difficult to do or tiring to do, they may try to offload some of it on their loved one. Like, you count for me while I do this, or you hold this for me so that I don't have to hold it. That would be you participating in their compulsion. That accommodates the anxiety. You might also like drive a loved one around all of the time because they're afraid to drive. Otherwise, protecting a loved one from anxiety can be accommodating. So not suggesting that you do something because you know it's going to be triggering for them. Changing the TV station when you see something that you know is going to make them anxious because you're anticipating it. Facilitating avoidance. This would be other ways that you're helping them avoid and helping them maintain their behaviors that are maintaining their anxiety. So that might mean you are giving them money because they can't, because they are resisting and avoiding and not able to work. Or maybe you are buying them soap and buying them lots and lots of soap because they are using a lot of soap in doing their washing compulsions, that sort of thing. And otherwise modifying your life. So if you feel like you're doing things differently because of someone else's anxiety, then that may be a sign that you're accommodating their anxiety. The reason that this could be problematic is that it reinforces the individual's belief that their anxiety is dangerous again, because you are protecting them from it, you're trying to help them avoid it. And it also prevents naturalistic consequences. So if someone is not seeing the consequences of their action because you're protecting their bubble of an environment, they may not be motivated to change. They may not be motivated to seek treatment because they're like, everything's cool, I'm cool. I've got this little bubble and I've got this person, or I've got this person I can depend on, I can call morning, noon, night, all the time. I don't need to go to therapy. That sort of thing may impact motivation for change. This is a direct quote from an article called "Someone I Care About is Not Dealing with Their OCD, What Can I Do About It?" And this lists 4 things. So number 1, learn as much as you can. Number 2, share what you learn with the person. Express your concerns to the OCD sufferer and the impact you feel it's had on their life and your own life. And number 4, normalize your life as much as possible. So when I work with families and I'm trying to help them help their loved one, I usually tell them, do less things. It doesn't need to be more work for you. Let's make it less work for you so that they have the opportunity to practice their own coping skills and learn that they can tolerate their anxiety. Also, it's healthier for you as a loved one to have your personal boundaries and know when you're getting drained and to, practice your own self-care. Some resources for education, also for treatment. Lindner Center, we have this big, great description at the beginning of all of the services that we offer. Also, the International OCD Foundation is a great resource. They have a website there, and the Anxiety and Depression Association of America has a great website. Both of these websites have a wide library of books and educational resources for families and for sufferers. They also have treatment directories where you can look by location, and it'll have, people who have identified themselves as specialists who come up as providers in those areas. And then you can also go through your insurance company to find providers that would be covered under your insurance. This is a huge topic, not one that can be fully, addressed in an hour. So I put on here lots of books. Some of these books are more specific for parents. Some of them are more specific for like partners. A lot of them are specific for OCD, but some of them are more for other anxiety disorders. If you're wanting more help, more education, I would encourage you to look at some of these books. Okay, that's all I have. So, does anyone have any questions?
I have a question regarding the table that you had, where you had information seekers versus reassurance seekers.
Yeah.
And this is in dealing with anxiety. And if I have this correctly, the reassurance seeking is part of an anxiety disorder.
Reassurance seeking can definitely happen in an anxiety disorder.
So if a person is reassurance seeking, what would be a response to, let's say, expressing their same fear over and over and over again? What would be a proper response?
That's a great question. I think it depends on your relationship with them and how good that relationship is. If you have a lot of like emotional collateral, you could just be like, I've already answered that several times, no more. I'm not gonna respond to your anxiety anymore. You could also do it more gently in, saying, I think you asked that yesterday. What did I say yesterday? That sort of thing. So you're not answering again, but you're asking them to think about what you said yesterday. Or having a discussion, an open discussion. Like, I've noticed that you do this a lot. I want to be helpful to you, and I don't think it's helpful that I answer all the time. Can we have a code word? Like, when you ask, what can I say? Because I want to be helpful. It really will depend on your relationship, how that goes. It can be helpful if a therapist recommends it. Good question, though. Yes.
With OCD and with teenagers, is there a way to like help them? They're not mature, they're not fully functioning brain, like, dude, your life is better. I know you said don't talk logically,
Mhm.
illogical, but
Yeah.
like, give me something.
Yeah, I think with teenagers, a lot of it, from my experience, comes down to like naturalistic consequences, like putting in naturalistic consequences. So if like I'm spending way too long getting ready in the morning and I'm getting to school late and I'm making everybody late, maybe if I'm late, I have to pay for an Uber myself. Or I have to, if I don't catch the bus, then I can't go. And I think teenagers respond really well to that and can see more how it's a problem if it is actually a problem. But it is hard when they don't care. And when they're like, I don't need to be doing all of these different things. I'm okay just sitting at home all of the time, or I'm okay doing my laundry for hours. But I always encourage parents to, again, do less, because oftentimes the parent is more stressed out than the teenager because the parent is doing more than the teenager is doing. And it's okay to step back from your involvement, and they end up doing more compulsions because then they see how big of a problem it is. And then they might be more motivated to see change.
of the child watching motion zone are now closed. Again, the child watching motion zones are now closed. Thank you.
Any other questions? Yes,
Okay, so when things are good, things are really good. And when things are bad, they're really bad. So how do you get them to just know that just the mundane and normal things are okay too? Does that make sense? When you have like, because you talked about the whole, what was it, feelings, thoughts, behaviors can all have whatever.
yeah,
But when when things are good and they're really good, everything's great. So then everybody around you is great. But when things are bad, things are really bad. So the behaviors come before the feelings sometimes. Does it make sense what I'm asking? So how do you just kind of get that, like, middle ground, I guess?
yeah, I think that's hard. I think sometimes when things are good and everything's good, that's also biased and not accurate. Right, so if I was seeing that person in individual therapy, I might have them explore more what, like, things aren't always good, like, things aren't always perfect and amazing. And sometimes that can be helpful in, managing the hard times too, because it's not like it has to always be perfect, it's not actually always perfect. What are two things that went well and one thing that didn't go well today? There are so many things throughout your day that are, make you feel a variety of feelings. And trying to like point that out more could be helpful. But that's a hard one, and some people are more prone to that black and white thinking of like, it's either all good or all bad. And sometimes in therapy, talking more about that can be helpful, and like knowing that I have that tendency to not look at the gray area, and to swing from one to the other, can be useful.
So I have a teenage, also, so with the CBT therapy, so possibly doing that, so there's not like one thing that he knows, it's more of like intrinsic thoughts kind of thing, so, like if he's home, then he'll do like his habits is what we call it and stuff like that, like he maybe like light switch or tap or do things like that, but if he's like in school, then he'll do things like kind of hurt himself, you know, like doll or bite lip or do things like that. But like, so how would you expose him to those things if they're different thoughts all the time? Like, it may be something different. So how would you handle something like that when it's not like, you know, you have to wash his hands all the time or he has to do something?
Yeah.
It's always some different thought that comes in his mind that he has to, if he doesn't do it, it's usually like I may die or something like that. He
Yeah.
doesn't have to, if he doesn't do whatever it is.
Yeah, so, I think even there, we can identify what are themes. Like, what are the themes that cut across the different places, and it doesn't really matter what you're doing in response. Normally, in the therapy, we would just work on not doing anything that comes to mind, whatever urges you have in the therapy room to make it so that you don't feel the anxiety anymore, we wouldn't do those. And we might try to bring those thoughts up on purpose, actually, or create a situation where they'd be more likely to happen. Sometimes the person is not anxious in the therapy room. Yeah, right. Well, we can get very creative, I will say, on bringing things up on purpose. And we really depend on the teenager or whoever it is to be invested in the treatment such that they can come up with ideas. Because I don't know, everyone with OCD is so different. I can't just assume what's gonna make you have one of the thoughts, but I imagine you have an idea what might bring on one of the thoughts, and then we would just kind of try to do that thing. But if we can't, then we might switch it up so that you're doing things other places. Or we might, if it's an outpatient sort of thing, I might do telehealth and have them do something at home, on your stairs or in your kitchen or whenever it comes up and whatever triggers are there. If they're only at home, then we would be in the home as much as we can. Yeah. Yes.
So you have a friend or a loved one that could probably need some help. How do you breach the subject without sounding too authoritative or too,
Yeah.
coming on too strong? How would you say, well, I think that you might benefit from seeing some professional help? What would be a good way to breach that without offending somebody or putting them on the defensive?
Yeah, I would make it, sometimes it can be, like, helpful to make it about you, like, I'm worried about you. I see this like really impacting your life, and I feel like maybe you need more help. Like I see you trying to do this on your own, and I don't feel like it's working. Maybe you need some extra help. The important part, yeah, is to not be like, you're bad, you need fixed, right? But I'm concerned and I'm offering a solution. You can take it, depending on how concerned you can be more forceful about that recommendation, but really coming from a place of caring and love. And then it's up to them to take it how they will. You know, all you can do is your best in that interaction. All right.
Any other questions
Yeah.
online?
Yeah, we have any online? Okay.
Yes. Yes, I have a question. I'm thinking about a very young child, 6 years old, who's quiet by nature and is afraid to perform in the classroom. Very intimidated by questions being asked, even though this person knows the answers. So, to the question, but is afraid to make a mistake or is afraid to be incorrect. How does a classroom teacher respond to that without coming across punitive by saying, you've already asked that question? I just don't think that would be an appropriate response for a classroom teacher. So what are some strategies a classroom teacher could put in place to help a child who tends to be a little nervous in the classroom in a new environment so that she feels comfortable performing?
Mm-hmm. Yeah, I think that's hard with that relationship that you have. It's limited in your influence. But I would encourage you to potentially speak with the child outside of the classroom setting, or express your confidence in their ability. So, you know, if they raise their hand and they answer and it's not exactly incorrect, still praising the fact that they answered and that they raised their hand. It can be tricky with kids and how much they want the spotlight on them and not on them, of course. But yeah, that's a really hard question. I could also involve the family, or I could even, how did I do that? I'll just leave it up. I would even maybe create a different way that might make it easier for that individual to participate. So maybe instead of raising their hand in class, they could turn something into you later in the day where they have a question about something, and even that